child mortality. And they wanted to do this by promoting evidence and accountability. Some of the products they produced during that MDG period were country profiles of a bit more complicated kind than we've produced right now, global reports, scientific publications, and 10 in-depth case studies. Now, obviously, the transition to SDGs changed everything. A much more complex landscape of global actors, many more issues on the agenda. Newborn child is continuing deaths, and now we were launching a journal at the very same time as the World Bank was hosting the finance ministers of the world, and they were speaking about the same thing. And we were high, quite frankly. And we said, you know what we need? We need a countdown. We need an accountability mechanism of the same kind. And a small, very dedicated group of people really pushed forward from there to produce and launch at the time of the World Health Assembly. When we launched the Nurturing Care Framework, we launched the country profiles. And as a result of the work we were doing, we were invited to formally be part of Countdown to 2030. Which up to then, as everybody and driving the problem. Development, conflict settlement, review meetings, regional initiatives, tended to, its main activities was to produce analyses and publications, to host workshops, all with the idea of keeping the progress in our minds. So producing data about the regions, about the countries that showed how well are we doing and where are we not doing so well. Where do the countries themselves, where do the aid partners, where does civil society and other people come in to put additional effort into those countries which are struggling to move forward. And so when thinking about our countdown, the countdown of nurturing care for early child development, we took as our starting point the conceptual framework of the Nurturing Care Framework. And that is, as Bernadette, the 5 components of what children need that they get mainly from their families, caregivers, and parents, situated within this framework of enabling policies, enabling services, enabling communities. So we wanted to reflect both those dimensions in our country profiles. We had to decide which countries. In the Lancet series, we calculated the burden of children at risk to not develop to their optimal potential. And there we classified 76 countries as having a burden greater than 30%. More than 30% of children in those countries were at risk of not developing their potential. Countdown had 81 countries. On the other hand, there are countries that do not have such a high burden of children at risk, but they have extremely large populations, so they contribute to the numbers. And those countries such as Brazil, China, Mexico, we've included, and so we ended up with country profiles of 91 countries. We added Argentina because of the G20 meetings, but it's not formally part of our countdown booklet. So the countdown profiles are themselves available, and I'm going to indicate to you where the websites are. They give all the technical details, they give the country data. On the website is all the data as well, and this is what we would like to encourage people to go in and look at. There's a simple file with the simple data that everybody can look at, and you can look at your country and scroll across the Excel spreadsheet and see. For people who are more interested in how precise the data is, they can look at the confidence intervals, the ranges, and so on, all in that data set. So we had to decide what data. Well, we wanted data that was relevant to the Nurturing Care Framework. We wanted recent data because many people don't know that a lot of our data is dated. It actually takes 1.5 to 2 to 3 years for information from a demographic and health survey to actually become available for public use. So we wanted we were looking at data anywhere from 2005. We wanted data that's available for most countries, and we wanted data that is comparable across countries, meaning the questions were asked in exactly the same ways. And that produces some interesting things, which I'll point out to you. We wanted data that was publicly available, that had been technically reviewed for its integrity. This is usually done by the UN statistical agencies, and all of the UN agencies have statistical units, or in peer-reviewed publications with country-level data, meaning people had actually had the chance to look at the data. So most of this data comes from the demographic and health surveys, or from the multiple indicator cluster surveys that are run by, respectively, USAID and UNICEF. Now, but in the profiles themselves, every piece of data, all the indicators are very carefully defined, and their sources given, and the dates of those sources. So we can check, because sometimes people come up to me and say, well, Syria, the breastfeeding rate has increased. Well, that might have been from their DHS last year, but that DHS hasn't yet found its way into the data set. So all of this is there available for the technical checking for people who are interested in that. So we have these 91 countries. As I say, the actual reports, each country profile, and the data sets are all available on the EGDAN and the Nurturing Care websites, and you can download all of that. So there's a logic to the country profiles. They start off at the top, giving some information about the country. It then details some threats to child development. They're not all the threats there are. They're the threats on which we currently have data. We have the numbers of children at risk of poor development. We have the lifetime costs to countries. We have the facilitating environment. We have policies to support families, and then the components of the Nurturing Care framework, and I'll take you through each of those. So under demographics, we include the standard things you'd want to know about countries. How big is the child population as a percentage of the total population? What's the infant mortality rate? And so on. We also detail threats to children's development, and we have put the poverty rates, children living, and under each of these components are indicators that are common, everybody can access them, but which we think are helpful to put together as indicators of the nurturing care components. So the health, we have things like the number of children who, I need glasses for this. This is a bit far away from me. Oops. Pregnant women who are receiving HIV treatment, caring for childhood pneumonia, which is a sort of in the home. Now you will see that what Bernadette pointed to, the missing piece, responsive caregiving, has no indicators. Currently, we have no way of measuring what countries are doing, and this is the big work for the future. So we have suggested some of the indicators we might consider are things like, does the country have a public information platform about early childhood development? Are there maternity leave, paid paternity leave, a national addition of children, a country adoptable, and the definitions under which they were? It's because care of weeks of the data and the way in which the indicators are, and 67% of children at risk for poor child development. That is the majority of the population of children in that country. The first thing you will see is that from 2005 to 2010 to 2015 has been a marked reduction in children at risk. We also see that where the highest concentration now remains is on our continent. So this problem is really coming home to us, and I'm very proud that Africans are taking the lead in trying to address these things. If we look at which countries have improved the most, the dark green on these maps shows countries that have actually reduced their burden by more than 20% over this decade. And so you see, I hope the maps are clearer to you, but there's some countries in Latin America that have reduced their risk by. There's a massive reduction of risks for children because both poverty and stunting were reduced. We also have looked at equity differences. I'm sure these maps are not very clear to you in the audience, so I'm going to skip the global maps and go to Africa maps. So here is the Africa map showing the reduction in burden. And you can see that throughout Africa we've seen, except for conflict states, we've seen reduced burden of varying degrees. Some countries really leading very strongly with large reductions, sometimes starting at very high levels. And so we have to look at what was the baseline when they started. If we look at the differential between boys and girls, the red portions of the map show countries in which boys have a lower risk than girls. But in fact, the risk differences are small. Where boys are better off than girls is often in the range of between 3 and 8%. In the countries in light pink shows that they're within 2% of each other. There's either -2 or +2%. The countries that are grey have no data. My own country is very guilty on the score, and I'm going to use the country profile to talk to South African Statistical Agency about we better start producing data comparable with our companion countries in Africa. But where we see huge differentials is in urban-rural risk on our continent. So the dark red shows that rural children have a 40% greater risk of poor development than urban children. This is really something that, this piece of data is something that we need to take home. The cost of growth failure. We calculated this as the percent of annual average income that is lost due to growth failure in the first 2 years of life. The countries in red are losing 200% of the annual average wage due to stunting of children in their early life. Those in the orange are losing between 100 and 200%. So in some countries, if we don't do more to promote early growth and development, we're pedaling backwards. So this graph needs to really demonstrate to us that we need to act in these countries to ensure the accumulation of human capital for the better, not only of the children affected, but of the society as a whole. So let me reiterate, the majority of the highest burden is now in sub-Saharan Africa, and we need to take responsibility for this, and I think this conference is our first statement of the fact that we are. But there are many risks to children in sub-Saharan Africa, way beyond poverty and stunting, and I just want to give you an example. Young motherhood, that is women having pregnancies before the age of 18, has a mean of about 28%, close to a third of women are having a young pregnancy. That often means that the development of the mother as well as the child might be constrained. Harsh punishment is something that needs to be much more on our agenda. This data comes from the model with an implement, has a mean of 83%. There's a very high rates of down to 2030. We have a technical working group. UNICEF will produce country profiles for the whole of Countdown. And the agreement is we will update the data sheets every year, but we will only update the actual country profiles every 2 years because data refreshes fairly slowly. EGDAN, the ECD Action Network, and the Partnership for Maternal Newborn Child Health, and others will mobilize and advocate and disseminate these reports. And we've already started regional analyses, including the kind of analyses that I've shown you today. So we need feedback. Was this useful? Can you see how you might use this in your country? We would very much appreciate hearing from you as to what kind of data you would like to see. And of course, this can't be done in a big conference. We would like to use regional and country meetings to delve into this data in more detail and explore with countries how they might want to use it. We want to therefore gauge the interest of countries in workshops, and we need to mobilize for funding to move forward. Now, the EGDAN platform has a whole knowledge platform, and all, as I said before, it's very easy to navigate, and all the country profiles are clearly indicated separately from the report by their country flags, and you can click on that and enter into your country and explore your data in much greater detail. So thank you very much.
Okay. I'm going to ask if there are any clarifying questions or questions from the audience about the data, and I'll actually start, Linda. So if you click on those country profiles, you get all of that data from each country, and what would you ask people to do with that when they print out their country report?
Is this on?
Just press. No,
this one. This one. Is this on?
Yeah.
Good. Well, I think it's hard to comprehend just listening to it in a presentation. You might want to be more careful. There is also other data that you might want to access that is not on the country profiles. But I think you might particularly want to see how your components of nurturing care and the indicators of the facility environment are responding to your burden and to the risks in your country. I think that's where the discussions in countries will center.
Are there questions from the audience? A few questions? Any? Do I see any? We're not, go ahead, right there. And you'll have to shout it out. Shout it out.
Really amazing.
Sorry. So really appreciative of all this work. I did observe, and we know in our continent in Africa, there's a lot of conflict and displacement and a lot of refugees. And it worries me that because perhaps we won't get the data, that's the nature of this context, that sometimes we don't get enough information to advocate. And I think a lot of children are being left behind. And I would love to hear your recommendations or any movements that you see coming so that we can address this crisis that is not being talked about enough.
I'm going to ask our colleague Gassan to whether you would be prepared to make a few remarks. I mean, clearly data from conflict countries is not very easily available. It's not very reliable, but there have been techniques to collect data in different ways to at least get estimates. So I wonder, Gassan, if you would be willing perhaps just to introduce yourself and then to speak to the issue of updating data on countries with conflict.
Yes, thank you. Thank you, Linda, Bernadette, and John for that. I'm Ghassan Isa. I'm a pediatrician. I'm the director of the Arab Network for Early Childhood Development, and I've been part of this process that we're being talked about since the beginning. I'm very happy. Now, about the data, first, let me say that we were lucky to get, for instance, the Arab Network to get funding to translate the country profiles to Arabic. And I think this is a very important issue, that not all the globe speaks English. And if you want to make use of this in advocacy and whatever issue you want, you have to have it in the language, local language or natural language that's there. This is first. The other is that we will try in this process to update things if there are issues to update. Now, definitely, the data from conflict areas is very difficult. But not that much. I mean, there are countries. For instance, let us take Syria. Syria is a conflict country, and there are areas that are difficult to get data from. Okay. Now, but other areas are accessible and you can get the data from. For instance, this is what happened, for instance, with the polio outbreak that happened last year for that. For certain areas, you can get data, but for instance, for the areas that are still under the control of ISIS, it's difficult, and we don't know what's happening there. This is just an example. In other countries, like, for instance, in Yemen, definitely there are areas that you can access and get data and areas that you can't. And in Iraq, the same. Thank you.
Yeah, I just want to add, and thank you for the question, that we've got a quarter of the refugee crisis in this region. So when people think about other regions, we really need to begin to have people focus here also, and thank you for that. I think Bernadette wanted to make a comment.
Just a very brief addition, that clearly we shouldn't forget about the obvious. So data would be fantastic to have, but even in the absence of data, we know we need to act. So if you look at the nurturing care framework, some people look at it and say, such important issues, disabilities, humanitarian, where is it? It's sitting there in small boxes, and work will continue. We now need to learn and deepen that guidance to say what's actually happening, what's the experience. And so within the partner community and through the ECD Action Network, we envisage that more policy guidance will come, that more practical examples will be illustrated of how action can be taken, and in that way, we hope that together we can create community that kind of lifts these issues that are so important high on the agenda and keeps them there.
Bernadette, were there not also, in the case studies that accompanied the nurturing care framework, some examples from conflict countries?
Yes, we had one practical example of the situation in Greece and how their care is being provided to these communities that are most vulnerable. And as we continue to work now, we hope to bring many more of these briefs into the public domain so people can take inspiration.
Panel here already. Please join me in thanking our speakers. And I just want to, yes. Before I turn it over to the next panel, I want to ask you to do 5 things, because I never leave the stage without doing that. Number 1, take your data and put it to work. You don't have to wait for this. Everyone should ask themselves, how many children are born in my community? If you don't know that, you need to find it out. Because if we don't even know how many children are born in our community, and we're hearing progress, thank goodness, on birth registration, we can't jump all the way over to this national data if we don't know that. So listen to families, listen to caregivers, use the data that is already available. Second, use every opportunity to get the message out. If your community is interested in jobs, talk about the jobs we can create. If they're concerned about health, link the nurturing care framework back to health. Reach out to new champions. We're not the voice of this data. We need to find even more people to be making those messages clear. Fourth, support each other in this work. This is hard work. Be persistent. You need a support system to get through it. And finally, and I think this is the most important point I could ever make, know that change is possible. I've had to remind myself of that lately, but I really believe that we can make a difference for children if we believe we can. Thank you, and thank our panel.
Okay, so if everybody for the nurturing care in practice presentation can come up. Dr. Warfa, Ms. Svetlana Doneva, Caroline Dusabe, Dr. Victoria Sargsyan, and Mr. Hilary Tanyaniwa. As we're waiting for them to come up, if people can kindly check their bags, we have one of the AfECN gift bags that had some personal items for the Minister of Education. If anybody can please, there are 2 gift bags along your far left, that end of the hallway. If anybody was sitting that side, if you can kindly check if you picked up the wrong bags, please, and bring them to our staff outside. Thank you.
Good afternoon, ladies and gentlemen. I'm confident you have been inspired by the statements you heard from the opening session and also from the last presentation. Great presentation from 2 great ladies. So now my task is simple. I'm going to introduce this panel discussion on nurturing care for early childhood development, focusing on really nurturing care in practice. That is really the topic of the panel discussion. We have a huge body of evidence on ECD interventions, but we are still in the learning curve how to translate that knowledge into practice. So we are going to hear a lot from these distinguished panelists. Maybe let me just highlight a few things that has been already emphasized, but I'll try to be as brief as possible in the interest of time. In view of the current global momentum and opportunities for resource mobilization, I think this is high time to focus on early childhood development really collectively, because no one can do it alone. However, we have still some challenges. As you have heard from the last presentation, majority of the countries with the highest burden are in Africa. And one of the risk factors is stunting. Stunting in Africa is still a big problem. 25 out of 47 countries have more than 30%. And 10 countries have more than 40%. And the trend is growing, it's not going down. In fact, if you look at the number of stunted children, it is increasing from about 50 million to 58 million. So we are not making progress towards achieving the target, SDG target. Anemia is also a big problem in the reproductive age group, with an average of 39%. Violence, you have heard from Linda, 83% of children have received hard or harsh punishment. 80% of the new HIV infection are occurring in children and adolescents in Africa, with all the consequences affecting growth and early child development. Premature birth is so high, and improved sanitation is at 42%. We need all this clean environment for children to thrive. Breastfeeding, the most effective intervention. The African region has a coverage of less than 50. Only about a third have achieved 50% coverage. But we have great opportunities, as we have heard before, in terms of really mobilizing all sectors towards the 17 SDG targets, which many of them have direct contribution to early childhood development. I want to emphasize that the health sector has the greatest opportunity to come in contact with babies in the first 1,000 days, and we're already doing a lot. So what is important is really to look at the entry point and identify the missing elements, the weak links, and try to strengthen the system in order to foster early childhood development. I must emphasize that the critical element of success in this noble agenda is really the high-level political commitment, like I have heard from the President. High-level political commitment, effective intrasectoral and intersectoral collaboration, and embracing all key stakeholders in order to really achieve or scale up early childhood development. I think in my view, we need to make a compelling case for member states, for our governments, to prioritize and invest in ECD as a key input towards fostering human capital development as a critical input to national socio-economic growth and development. Just want to cite a quote from Nelson Mandela to show how governmental commitment to what we are saying. The true character of a community reveals by how it treats its children. I think this is how we should be judged. Finally, I welcome the diverse range of distinguished panelists from 6 countries who will bring different and rich experience during this panel discussion in really putting nurturing care in practice. I would like to briefly introduce the moderator of this panel discussion, Ms. Maniza Nteken, the Regional ECD Advisor for UNICEF SARO based in Nairobi. Over to you. Thank you.
Okay, good afternoon, ladies and gentlemen. Now, you know the VIPs have left the room, huh? So I think now is that, you see, I've taken my jacket off. I think you can take your jacket off, kick off your shoes, loosen that tie. We are now going to have an interesting session, aren't we? Now is about the work. We started already discussing the work before, and we're going to continue today. So I want everyone to feel relaxed. So what we're going to do, I've got one question or so to ask our panel members, who I'm going to introduce in a moment. Then I'm going to turn to you for some brief questions, and please brief. I know we have doctors and teachers in this room, but we are having no lectures today. Brief comments so we can capture as many as possible. I'll turn it back to the panelists, and then we will close. Okay? So let me start by introducing from my left. We have Dr. Victoria Sargassian. She's an ECD expert from World Vision, and she is momentarily going to take us to Sudan. Next to her is Dr. Usman Wafa. He's the head of Neonatal, Child and Adolescent Health Unit here in Kenya from the Ministry of Health, and he's going to keep us in Kenya. Then to my right is Mr. Hilary Tanyanyiwa from Zimbabwe. He's the OVC Program Manager for the JF Capneck Trust. He's going to take us to Zimbabwe. Next to him is Ms. Caroline Dusaba. She's the ECCD specialist from Save the Children. She's taking us to Ghana. And then at the end, last but not least, Ms. Svetlana Doneva. She's communication specialist for Alifa Labantwana, and she's going to take us to South Africa. So we are going on a tour of Africa in this session. And I want to start actually by addressing the first question to Dr. Wafa, because I think it's important to get that government ministry perspective first. We've heard so much over the session this morning. We know we've had some discussions for the rest of the week on the importance of the Ministry of Health in terms of supporting the first 1,000 days, most critical period for human development, and supporting parents and young children. But I want to ask you, from a government perspective, from a Ministry of Health perspective, you've got so much on your plate, but what are the 3 maybe or 5 key things that you think ministries of health must focus on to better support caregivers and young children? Over to you.
Hello.
Oh, turn my off.
Good afternoon. It's a pleasure to be here, and of course I will straight away go to my responses to what I've been asked. First of all, in the Ministry of Health, I think our Cabinet Secretary was here this morning. So as MOH, this provision of leadership and policy support to enable environment, to nurturing care in all that we do as MOH. Specifically, what we are doing, we are actually integrating nurturing care framework into all the services we are providing. Building capacity of healthcare workers, community health workers, they choose building their capacity in terms of skills, knowledge and practice, so that they can also build the capacity of caregivers, so that they can respond properly, they can improve their interaction and all that. So in addition, they are marginalized communities. They are hard to reach areas in this country. So we have a Malezi Bora program. Malezi Bora is Kiswahili, which means Child Health Action Days, which takes integrated services to those communities and families, so that they are able to promote nurturing care in that kind of. Still, what we are doing, we actually are scaling up baby-friendly hospital initiatives and community baby-friendly community initiatives, so that they can initiate, promote breastfeeding, nutrition, play and stimulation, so that so the families, the community is actually enlightened that we start nurturing care as early as possible. Of course, prematurity is an issue in Kenya, and low birth weight babies. We have about 180,000 premature births, and about 8,000 of those babies die. So what we are trying to do is scaling up skin to skin. That is kangaroo mother care, which actually promotes breastfeeding, interaction, bonding, and brain development. Kenya has 47 counties, and we managed to reach 27 out of those 47 counties as far as KMC is concerned. Of course, we are rolling out universal healthcare coverage. Specifically, a large chunk of funding goes to mothers and babies and children in this country. They are not left behind, but there is also specific subsidies for children with disabilities. We want to work in a collaborative manner. We are consulting with our partners. We are mobilizing resources, embracing public-private partnership to raise funding for nurturing care activities in this country. So I'll stop there.
That's fantastic.
Thank you very much.
Thank you. So I think you need to turn yours off. So thank you very much for that. You touch on some of the critical elements we've heard this morning, and you make it a bit more concrete for us here, talking about the leadership, how you focus on marginalized groups, thinking about how this should be embedded in a system, which is why you have the universal healthcare approach, partnership and resources. And I'm sure you'd agree that one of the other key components is the caregivers themselves and what they need to do and how they need to be supported to enable their children to have the best start. And I'm going to come in here with a question to Svetlana, because Elifa Labantwana in South Africa has been supporting efforts to do a campaign around early childhood development to really support parents and give them ideas for how they can foster and enrich the environment within which their children are growing up in, so that they can have this nurturing, caring environment to grow up in. And so I'd like to ask you really, in your view, what are the core components needed to make such campaigns work to really change behaviors?
Sure. Thank you so much, Manisa, for the introduction, and good afternoon, everyone. As Manisa indicated, our organization, Elifa Labantwana, supports the National Department of Health in the implementation of a campaign which was launched this year. The campaign is called Side by Side, And the campaign has as its goal to ensure that all children under 5 receive the nurturing care that they need in order to develop to their full potential. And before I go into it, I just want to just touch on that side by side, the name or the brand of the campaign and what it actually refers to. So I think we've heard this morning that without supportive relationships around the caregiver and the child, that optimal development just doesn't happen. And it starts with the relationship between the caregiver and the child. It extends to the relationship with the healthcare worker and the close family, and further out into the community and other stakeholders and other government service providers. So all of those supportive relationships need to work side by side together in order for that optimal development to happen within the child. And that is why the campaign is called Side by Side. And what the campaign does is it supports and it informs caregivers of children under the age of 5, as well as pregnant women, to take the best actions in order for their children to develop best. And the way that it does it, and I think this is the components that you're asking me about, is it does it through 2 ways. The first is through a change in an approach in the healthcare system, and the second is through mass communication efforts. So I'm just going to touch briefly on both of those. So in terms of the change in the approach in the healthcare system, so the campaign is owned by the National Department of Health in South Africa, and that is so important for its sustainability because the public health system touches young children and pregnant women at multiple points during the first 1,000 days. And so that is kind of, that is what underpins the importance of this campaign living within the National Department of Health. And the National Department of Health has shifted their focus from children surviving to a focus of children surviving and thriving. And with the understanding that for children to thrive, they need a wide range of services which extend beyond what the Department of Health can provide them. So they are using all of these touch points that they have with the child and the caregiver in the first 1,000 days to create links to those other service providers, to those other stakeholders that exist in society and in communities that can support that child development to happen. And that is what that shift looks like. And I just want to show you what the practical application of that shift is at this stage in the campaign, which is quite new. And it's the Road to Health book, this is what it looks like. And this is the book, and I know every country has a version of this. It's the book that is issued to all children at birth, and it's a health record of immunization and growth and health interventions. And previously, this book in South Africa was a clinical book, which was for the healthcare worker. Now this book, which has been relaunched in line with the Side by Side campaign, it is a tool for the caregiver. It's information and support for the caregiver. So there's a lot of content in here which is there to do that education, that supportive function. And it includes information that is wider than just what the health services are that the child needs. It also has information, for example, on how to access social grants, like the child support grant or the disability grant in South Africa. It has information out on how to stimulate children, how to love, how to play and talk with them within the first 1,000 days so that that brain development can take place. So this is the book, and if anybody wants to come take a look at it in more detail, they're more than welcome to come find me afterwards. Before I move on to the mass communication side of the campaign, the second really important component, I just want to say that this tool has another function, a third function, and that function is to facilitate a conversation between the healthcare worker and the caregiver. And through that conversation, that is where that supportive relationship starts to build. Because we can't have supportive relationships unless we talk to each other. And often there is an imbalance of power between the caregiver and the healthcare worker, and often the caregiver might feel intimidated about asking questions. Okay, so let's move on to the mass communication, because this is really exciting. It's a lot of things that the National Department of Health in South Africa hasn't done before when it comes to early childhood development implementation. And before I delve into those communication channels, I just want to say what is the Department of Health, or this campaign rather, what is it actually communicating to the caregivers? All of the messages in the campaign are divided along 5 pillars. We call them the knowledge pillars of the side-by-side campaign, and having just heard the presentation on the nurturing care framework, you might have remembered that it also has the five components. They're extremely closely aligned to those. So we have nutrition, there's love, which refers to responsive caregiving and creating opportunities for early learning. There is protection from injury, from disease, and from other harm. There is health care, and then there's extra care for children and for caregivers that might need extra support, like, for example, those who might be living with a disability. So those are the messages, and they are all framed within the context of this is what the child needs in order to thrive, and that is how they are communicated to the caregivers. The way that they are delivered to the caregivers is using a media mix that takes into account how behavior change happens when we consume information. So we are using face-to-face, of course, within the clinic, probably the most important way, but also mass communications like radio. So radio is probably the best way to reach a lot of people, especially in the South African context. The campaign has a radio show. It's called Side by Side, and it's a drama, which is very effective for modeling complex behaviors, because I think when information is delivered in a very kind of prescriptive, didactic manner, sometimes it doesn't hit that emotional part that we all have inside of us. And I think when a message is delivered through a storytelling, through a dramatic component, the information is absorbed better and actually has more of a likelihood of actually affecting behavior change. So there's a drama radio show, which is a weekly show, and it's on 11 public radio stations. It reaches over 4 million people in 9 of the 11 official languages. Then there's Facebook. So Facebook, it's a little bit unorthodox, especially for a public health intervention, but that is where our caregivers are. And Facebook provides that unique opportunity for actually the caregivers to communicate back with the campaign. I think in this, in 2018, we cannot just communicate to people and not expect them to want to say something back, because that is just, the world doesn't work that way anymore. And all campaigns need to take into account that they have to have a platform where people can engage with the content and they can ask questions, and they can also form their own agencies amongst themselves, and that is also part of those supportive networks. And Facebook is at this stage one of the most practical ways to do that, because first of all, it's free, and second, our target audience is already on that platform. Then the campaign is also integrating some existing programs of the Department of Health. There's one called Mom Connect, very important program which has been running for just over 4 years, and it's a text-based messaging service which sends direct WhatsApp or text.
Lana, can I ask you to just briefly summarize?
Yes.
Thanks. Sorry to.
I was sure. So I think a lot of people probably do know about Mom Connect, so I won't go on much about it, but I'll just sum up to say that these communication channels, and there are a few more, all act together to send the caregiver to another place where they can hear the message again, because repetition is really important, and they're all saying the same thing in different ways, but they're delivering the message based on where the caregiver is in their parenting journey, so the message is most useful to them and is most likely to lead to behavior change. Thank you so much.
Thank you very much, and I am sorry to have interrupted you there, but I think colleagues can grab you definitely, because that sounds like an interesting campaign that maybe we could be replicating in other countries or getting lessons from. So we've heard a lot, both from Dr. Wafa and from you, Svetlana, about this important interaction between caregivers and health workers, so maybe primary caregivers and secondary caregivers, and that's a really important and complex relationship. And we know that in Ghana, Caroline will tell us, Save the Children have been supporting the integration of nurturing care and stimulation into existing nutrition programs that they support. And we often hear the case that we have to integrate, we have to call on the health worker to do this, that, and the other. So I would like you to tell us about how this has worked, especially in a situation where health and nutrition systems are probably already quite burdened. How has this worked in your context?
Okay. Thank you so much. Just to share a little background about the project in Ghana. So the project is implemented in partnership with JAPIGO, so Save the Children and JAPIGO are implementing this project, and it is part of a bigger maternal and child health program called the Maternal and Child Survival Program. Most people know it as MCSP, and it's funded by USAID. So we were privileged to have an opportunity to integrate ECD into the existing work of MCSP in Ghana. But before we decided to work through the health platform, we carried out a lot of focus group discussions with different stakeholders, including the Ministry of Gender in Ghana, to identify the best platform and the best touch point, because we did not want to make an assumption that, the health system and the health platforms are the best. But in the end, we were able to identify the health platform, and specifically the CHIPS. In Ghana, the CHIPS is the Community Health Planning and Services, and it's a nationwide program in Ghana that is very successful and well built. So we identified this as a best platform because it has existing structures and functioning structures from the national level all the way up to the community level. So at the community level, under the CHIPS, there are mother-to-mother support groups in most of the regions in Ghana, although not all of them have active groups. And these groups have been running for very many years. They were set up in the 90s as part of a initiative around breastfeeding and nutrition. So these groups have survived many years. So we felt that this was going to be a good platform, but also we went ahead and met a number of these mother-to-mother support groups to ask them if they would be able to do early stimulation messaging as part of their everyday activities, if they had the bandwidth, if they had the time and the interest. And we also talked to frontline workers like nurses and midwives to gauge the interest, but also the bandwidth. As you've noted, most of our health workers are really overburdened, they're overstretched. So we wanted to be able to make sure that we don't increase the burden for them. So what we did in order to ensure that we are not overburdening them, we asked them what are the opportunities, what is the time, the smallest time or the most time they can spare to add early stimulation messages to their existing messages and discussions with parents. And they were able to tell us how much time they can be able to put aside. We also asked them how they normally deliver the messages, what materials they use, because we wanted to be able to tailor our curriculum to fit with what they are used to, so that it's comfortable, it's a structure that they are familiar with, and it's easy for them to incorporate in their daily work. So they were able to tell us, for example, they like using posters for having group discussions. They were able to tell us that for a group discussion with 20 parents, they need this kind of material, but for a 3 to 5 minutes, they need a poster that is much more summarized, for example. So we went into this kind of details. And once they gave us this detail, we adapted the curriculum, an existing curriculum from Save the Children that has been tested and piloted in different countries, including in Rwanda, where we had the good, good impact of the program. So we're confident that it has worked in Africa, but also wanted to make sure it's applicable in Ghana. And finally, the adapted materials we have currently have responsive caregiving as a topic area, early communication and language, and we also included positive parenting, and particularly under the positive parenting, we also added a safety component. Because we noticed in the health sector, they're already talking about safety and protection from diseases, but we wanted also to talk about safety, physical safety of the young child. As you know, young children like to play, they're on the ground a lot, so there are so many, they're vulnerable to whatever is in the environment that may be harmful. So we included a session around protection from physical harm in the environment, as well as positive discipline for young children, which for us we say is positive guidance. And with these sessions, they were able to integrate into other existing messages on nutrition and health. So you asked how did we ensure, or what kind of learning we can share around making sure that nurses, midwives, other health practitioners are not overburdened. Key ones, yes. So I think the most important thing is to talk to these frontline workers. A lot of the time we have good packages from the global level, from the national level, that make some assumptions about what is possible on the ground. We assume they will have 40 minutes, when in actual sense they have only 10. So it's important that we ask them what is possible, what are the opportunities, and then we adjust our materials, our curriculum to fit what is possible. So flexibility is very important. So while we are building good training toolkits, we need to have that in mind, to have materials that can be taken. You put in provisions for, if you have 5 minutes, this is what you can do. If you have 20 minutes, this is what you can do. If you have an hour, this is what you can do, so that the frontline workers can use what is really possible and easy for them. And the other thing is to make sure that you align with what they're already doing. It sounds very simplistic, but if you bring in a new structure of carrying out a discussion with a parent that is different, even slightly different from what they're already doing, it's going to require this person more time to learn this new way. So if you can ask them how they are doing the good practice, of course, this is what we should adopt, and then align to that structure, it can really help. And making sure you give them the materials they need to work. For example, you can tell them, tell parents to play. But what if I don't know how to play? I need some games. I need a number of games, a kit of games to teach to parents. So this can really ease their work and reduce the preparation time. So they don't have to go to Google and start downloading games because you have already provided this. Yeah, thank you so much.
That was really practical. I hope people were taking notes for those of us who are always talking about integrating into existing systems. I like that first one of talk to the people first. So we've heard from Kenya, from South Africa, from Ghana, from countries where perhaps they have more robust systems, perhaps they have human and financial resources more than some other countries in our region, and perhaps they have had more experience and opportunity to build these robust systems. So I want to turn our last two panelists to maybe slightly different contexts, and I'm going to start first with Victoria. So please tell us, you do a lot of work and World Vision supports efforts in Sudan. So can you tell us how children living in these much more fragile contexts, like Sudan, can also benefit from access to an integrated system and how it works?
Thank you for the question. Let me start with the definition of WHO about health. That health is not, that health is a complete state of physical, mental, and social well-being. However, the operationalization of this definition has remained maybe not well implemented for many decades, more than 30 years. And we know that how it is important for early years and in the context such as emergency. But this survival kind of programming remains as a main mode of operation in emergency contexts. And the statistics from their world saying that, from 2016, saying that around 60% of the emergency responses, they do not include early childhood development programming in their interventions. So since 2013, World Vision started investing and exploring intensively in early childhood development programming, internally, externally, including the Lancet series, and also heavily based on the programming from external and internal programming. And we started outlining the programming for early years for 1,000 plus days. And we started implementing the research or pilot testing the effectiveness of that model in developing context and then in fragile emergency contexts. So in Sudan, 2016, which was implementing a World Food Program project for refugee in South Darfur state, implementing a community-based integrated nutrition program, they were reaching out to children with severe acute and moderate acute malnutrition. with treatment and prevention regimen. We decided to also pilot test our early childhood development package, which is called Go Baby Go, for this target population. And we randomly selected around 500 kids and allocated them to control, which received only nutrition package, and intervention where we added the Go Baby Go, which is about strengthening the parental capacities, especially in the missing elements of components of the nurturing care framework, that is early stimulation, responsive caregiving, safety and security, and this additional intervention package has been integrated into this platform, as I said, using these waiting periods of supplementary feeding centers and also making that space as a place for making the toys and also organizing the home visits, monthly home visits for the families with malnourished children. And we really registered outstanding results, statistically significant change in treatment outcomes. We have children in intervention group cured around 30% more than in control groups. We also have 8% less of the default rate and only 11% non-recovered compared to 33% of non-recovered children. So in terms of recommendation, what will be the recommendation is that these combined interventions are effective when we integrate nutrition and also early childhood stimulation. We also registered that this kind of integration is really low cost. It doesn't require a lot of resources. We use the same delivery cadres, our community volunteers, who were trained and given very simple resources on how to communicate, how to work with the parents, how to do the home visits, and it's also fun because parents are so much used to these heavy topics about health, nutrition, and now early childhood development, which is about play and communication and interaction. So want to say that World Vision remained committed, and we will not stop here. We will continue to do more evidence on the effective packages for emergency fragile context, and we would like to bridge the gap through advocacy with our key partners, stakeholders globally, to cover the gap of underfunding and also, I'm finishing, underfunding and deprioritization of early childhood development. We need to have this mental or cultural shifting from this survival to thrive and development mode. Thank you.
Thank you. I don't know about I hope everyone isn't in that supperific mood after lunch, but if you hear what she has just said to us, combining the stimulation with the nutrition intervention had a statistically significant impact. Doesn't seem to have cost so much, and it was actually enlightening and fun, probably for families and mothers and fathers in very difficult circumstances. There's a ray of hope, there's a brighter future. That's incredible. We need to clone you and send you out around the world with that message. Thank you very much. So, final panelist is Hilary from CAPNEC. Now, I don't think there's anyone in this room, any student of ECD, who hasn't heard about Sally Grantham McGregor and the fantastic work she did in Jamaica with robust research supported by the University of West Indies, looking at the importance of what you have said as well, integrating home visiting, stimulation, support for parents with nutrition interventions. And we trade still today on her evidence. What Hilary has done in Zimbabwe is, through the CAPNEC Trust, is look at how to model that, develop that, adapt that to the Zimbabwe context. And so it would be great to hear from you, Hilary, how that has worked, how the home visiting that you've done has worked, and in your view, what it might take to scale up such an approach.
Okay, thank you, Manisa, and good afternoon, everyone. I think as Manisa has just said, as CAPNEC Trust, we adopted the Jamaican Reach Up model, which consisted of doing 4 home visits to children every month. We adapted that to suit the Zimbabwean context, and we changed that to then have 2 home visits per month and 1 group visit. Having noted that in a rural setting, 4 visits would be too frequent for the home visitors because of the distances that they must travel. So we made an adaptation to that particular model, and as Cabinet Trust, being supported by Open Society Foundations, we are conducting the intervention, and then the Great Zimbabwe University, supported by the University of West Indies, is then doing the evaluation. So we adapted the model, and we also adapted the curriculum. That is the Reach Up curriculum. We adapted it to suit a Zimbabwean context by changing some of the materials in there, as well as making use of locally available toy production techniques to make it low cost and to make it easy to use in a rural Zimbabwean setting. So we had the 2 home visits and the 1 group visit per month. And in the group visit, we do parenting support training, as well as also some components on child protection. So it's been very exciting to see how this particular model has worked in a rural setting and in a very low-cost rural setting. Because it's been a very simple intervention, but has been very effective in terms of the impact on children and caregivers. And so far, we have results from a midterm evaluation that was conducted by Great Zimbabwe University with support from University of West Indies. And the results on the children are showing an increased concentration span. And these children are being looked at versus a control group of children who have not received the intervention. And we have seen that the children have gained knowledge and skills in terms of basic skills such as sorting and matching, identifying shapes and colors, picture recognition, and motor skills. By the way, these are young children from 6 months up to 3 years. We have also noted that the children have got now a better knowledge of the environment and the way they interact with the environment. And critically for us, we have found that the children have developed more positive relationships with their caregivers and even with the home visitors as well. And their language development has greatly improved. Of interest as well has been the impact on the caregivers. We have noted that the families have been brought closer together by this intervention. And what is key for us is that we are well aware that in a rural setting, caregivers spend quite a bit of time with their children. So what we are asking them to do, or supporting them to do, is to make better use of that particular time that they spend with the children. In the course of their routine daily activities, they then inject those stimulation techniques to be able to support and help their children to grow. And we have also found that a very interesting and exciting byproduct of this training has been improved involvement in the life of children by the fathers. We have had an increased number of fathers who attend the group sessions, and we have found the fathers taking an interest in terms of spending time with the children and also being involved in those infant stimulation activities. We have also noted that there's been an improvement in terms of personal hygiene, in terms of how the mothers take care of their surroundings and take care of their children. This for us is especially relevant in a rural setting and especially relevant as well with the recent outbreak of cholera in Zimbabwe. And we've also found that the caregivers have been very excited in terms of the ability of their skills to make use of everyday materials around the home and how they can use these to make toys for the children. Often children had no toys because caregivers assumed that you'd have to buy material. But they're able now to make very low cost, but also very stimulating toys from locally available materials. And finally, we have found that there's also been improved knowledge on nutrition in terms of how to support the children to have better nutrition and to prepare them for school. In terms of scale up, this has been one of the key areas we've been trying to focus on. That how can we now look at this intervention which is taking place in a particular district and scale it up to a bigger level. And we have noted that there's need for improved policy development. I think Zimbabwe has done a lot in terms of development of policy on ECD, and we have a very strong policy in terms of ECD for school-going children, that is pre-primary, the 3 to 5 year olds. But at the same time, we have to strengthen in terms of a holistic policy for those who are from 0 up to 3 years old. and this would be able to assist scale up of such a particular model. We have seen as well a need for improved intersectoral collaboration. The model we have been running has been implemented through the Ministry of Education with support from Ministry of Health, and we have seen that there's need to increase the collaboration between these key ministries as well as Ministry of Social Welfare. They both have got very good interventions that run within their ministries, but maybe operating more like in silos. It is key to bring these things together to be able then to give a holistic service package for children in the 0 to 3 age group. And we have also seen that there's need for us to improve, as civil society, working together with government, to improve on data collection for advocacy, to improve on simple data collection tools, and define simple indicators that can be easily collected at local level. And these indicators can be used to then track the program, how well the program is running, and can be used to inform decision-making, and can be used for advocacy for more resources, both from government as well as from other stakeholders who play a role in terms of providing ECD services to children, and also just to lobby for the scale-up of this particular model. Thank you.
Thank you, Hilary. Can you put your thing down? Thank you very much. Thank you to all of you. I think we've got time for just one super quick round of questions. So if you have anything, any burning questions, please raise your hand. Okay. Woof. Okay, I'm going to take, in the interests of diversity and equity, there's one here, and then there's one in the middle there. Maybe one at the back there. 4. But brief as you can. So there was a hand up here. Do you want to show your hand up here? Here it is. Thanks. Please, as brief as you can.
Thank you very much, panelists. I just have one quick question to ask. In the interest of the ministry, in the interest of the nurturing care framework, we know about mother-baby bonding. We also talk about breastfeeding. And we know about re-entry policies, the school readmission policies for our teenage mothers. And this is one policy that is really talked about in Kenyan context. I really don't know about the conversations that are there between the Ministry of Health and the Ministry of Education to actualize this policy, because I know the school environment where our girls go back when they have babies is not really responsive for these two aspects of baby and mother bonding and again breastfeeding. Thank you.
Yeah, thank you so much for the presenters. I have a bit of a concern, and the concern is the presenters here have actually been presenting about children under 5. And now we are talking about nurturing care and 0 to 3 years. So I kept on thinking about myself. Are we dividing this child into too many compartments? Could we extend nurturing to 5 years despite the science? That's what I was thinking. Because everybody has been talking under 5, under 5. Now when we be reporting, shall we be reporting nurturing under 3 and then under 5? Are we duplicating or are we having an issue here? That's my concern. Second concern is this. You've talked under 5, but we've not looked at children from 5 to 8 years. What are we doing about those ones? Because they are also living from families and caregivers and transiting to another institution, which is the ECD centers. How are we passing the information to the caregivers at the ECD centers?
Okay, my question is the panelists from Ghana. What strategy do you have? What strategy have you put in place for nurturing care to sustain quality in the rural areas in Ghana? And what are some of the challenges you have faced in implementing your program?
Four questions in 3. I love it. Okay, so just to summarize, I think it's for you, Dr. Wafa, this question about the policy on re-entry for girls who have had babies to go back into school. I think the question was, the policy is there, how it's being implemented. The second question about splitting up children, I think I didn't actually hear that from the panelists. I heard about them campaigning for support to parents across the board for nurturing care. I heard about integrating of programs that support children and parents, and I heard the same thing from Hillary about school readiness as well. But also to let you know that tomorrow and the subsequent days, there are actually going to be razor focused on all the areas that you've raised as well. But I do take note of a critical point you've made, which is, are we keeping the same message about integration, or are we only focusing on a particular age group and a particular sector? I think everyone on the panel would say that's not the way we want to go, but I thank you for raising that point. The third one was directly to Ghana about the nurturing care and the particular challenges in rural areas. So we'll go to Dr. Wafa first about this policy issue, and then to Ghana.
Okay, that was actually a great question. In Kenya, what we do is the girl, once she is pregnant, actually, she can continue to stay in school. While she is in school, in some schools we have even other programs like the weekly iron folic acid supplementation. So she will continue to get her supplements so that even the issues of anemia and all that is addressed. So she will continue to stay in school until her EDD, expected date of delivery. She's allowed to go deliver and come back and continue with her studies.
I think her question was, how is it being implemented? She had a question about whether that's being implemented.
Yes, this is being implemented at a country level.
Okay, thank you so much. In response to your question, I think the biggest strategy or the best strategy we have used in Ghana is to work through an existing government program. As you know, the CHIPS is a government of Ghana program run by the Ghana Health Services. So he already has monitoring, supervision, capacity building activities. So we have tailored our program to fit within the activities of the CHIPS, and we have engaged the Ghana Health Services team at all levels, including national level, regional, district. At all levels, we have engaged with the team from the start, including in the situational analysis, identifying the platform, adapting the curriculum, and we have good buy-in from the government, and also we have buy-in from the field staff, the frontline workers. And one of the good things that are happening there right now is that the monitoring supervision to the nurses and midwives who do the frontline work of passing on these nurturing care strategies and messages to parents is done by the staff of the Ghana Health Services. And they've included this in their monthly and weekly monitoring and supportive supervision activities. So I think this is going to be sustainable. You asked about challenges. One of the challenges is that our core way of meeting parents was mother-to-mother support groups. This was the initial platform and touch point we identified, but we found that in some regions, especially the urban areas, for example in the eastern, especially the districts in the urban, these mother-to-mother support groups are not as robust and active as in, for example, Upper West. So what we have done is to work with the nurses and midwives and other healthcare providers to identify other platforms. And one of the platforms they identified, for example, is working through church groups and other religious groups where there's already organized meetings. In some districts, they've suggested working with the cooperatives, for example, groups of women sellers, so that we meet the parents where they are and in organized groups, so we don't have to start new groups. And also we found a new and interesting exciting request from daycare providers, which in the beginning we had not thought about this platform, but daycare providers are really interested in having their capacity built on nurturing care so that they can train the parents who bring their children to this daycare center. So we're really excited. In the last quarter of this year and the first quarter of 2019, we're going to be working with some daycare providers, especially in the urban areas, which is really exciting to see that you can start with health, but if you work with frontline workers, they can advise you what other additional platforms can you bring on board. And for us, we are here to support with capacity building, with the any other support in terms of the technical elements of the program. But really, the program is owned by the Ghana Health Services. Thank you.
Thank you. Well, thank you so much to all our panelists. I think you heard from their examples what we've heard as a running theme throughout this morning about the importance of the systems approach, about the focus on vulnerable groups, using a smart evidence-based approach, supporting secondary caregivers and empowering them to be change agents in their community, and thinking about how we communicate best with primary caregivers and giving them a start. I think the debate will still continue about whether there's a particular focus on an age group to the detriment of others. I think that's something we should continue discussing and exploring. And I would say to the colleague who asked the question about the re-entry of young girls, you might want to pigeonhole them at coffee to, get more of a deeper answer on that one. But just left for me to say thank you so much to our panelists. Please join me in clapping for them. And to welcome the next session. Thank you.
Good afternoon. Next session is a very short session from AfECN Union. I don't know, should we do a little, a half second energizer? Would you like to stand up? Can you use your body to put early childhood E? Can you demonstrate the E? I don't know. Like this? E and C. Okay, thank you very much. I hope you are a bit energized. So next session is a very short session on advancing early childhood through AfECN Union Commission Agenda 2063. I think you are all aware of Africa Agenda 2063, Africa We Want. I forgot to introduce myself. My name is Yumiko Yokozeki. I'm a Director of UNESCO ICBA, International Institute for Capacity Building in Africa. We work on teacher development, including, and most importantly, early childhood teachers. So, we have Mr. Mitses Ousu, did I pronounce correctly? He's a program officer for education from AfECN Union Commission, Human Resources Science Technology. He's representing Dr. Beatrice Njenga, head of education in the same division. So you're going to have about 7 minutes. Okay. Thank you.
Thank you, Yumiko. Distinguished ladies and gentlemen, permit me to have the privilege to present on behalf of Dr. Beatrice Njenga, Head of Education Division at the Department of Human Resources, Science and Technology of the AfECN Union Commission. I am honored to have the opportunity to share with you some of the work that the AfECN Union Commission is doing in the area of early childhood education and development. The African continent, as we all may agree, is full of tremendous promise and demographically the youngest in the world. Realizing Africa's potential and aspirations depends on the investments that are made today towards the development of Africa's children. It is for this reason that the African Union places at the forefront of its priorities the transformative role of education and training in building human capacity to empower our youth, women, and marginalized groups. The AU Agenda 2063 and its strategic framework emphasizes the achievement of socio-economic transformation of Africa over the next 50 years. Key to this transformation is education and training, anchored in strong science, technology, and innovation. Early childhood education and development is the essential foundation for this. As stated in the Continental Education Strategy for Africa, a famous book also says, train up a child in a way that he should go, and when he grows, he will not depart from it. This means the desired values, attitudes, dispositions, and indeed potential in the population must be nurtured and developed from early years. CISA 16 to 25 states that early childhood education and development is the pillar for future learning and identifies it as the next frontier for Africa to realize sustained quality education and training. The African Union Commission considers early years as presenting a time of great opportunity and are decisive for human development. Hence, this calls for strengthened action to enhance investment and engage stakeholders in early childhood education and development. Ensuring strong foundations for Africa's children calls for intentional efforts by governments to safeguard children's access to high-quality, nurturing environments in their early years. With the growing realization of the importance of the early years comes the need for policies, programs, and services that are aimed at creating an enabling environment for all children, especially the poor and the marginalized. A multi-sectoral and interdisciplinary approach is essential to meet the needs of children, and the education sector is a natural point of convergence. In a bid to ensure zero hunger, promote child nutrition, avoid mental and physical stunting, and promote access and completion of education, the African Union is promoting homegrown school feeding. It is clear that ECED must be seen as everybody's business to ensure that adequate resources are mobilized, starting from government to local sources, to establish multifaceted, robust support systems for early childhood. The African Union Summit of Heads of State and Government established a committee of 10 heads of state and governments to champion education, science, and technology. And ECED is one of those areas which the Committee of 10 has to deal with. It is therefore expected that with the support at the highest political level, ECED is poised to take up its rightful place in government efforts as social inclusion, education, and training. In CISA Strategic Objective 2, the need to build, rehabilitate, preserve education infrastructure, and develop policies that ensure a permanent, healthy, and conducive learning environment in all subsectors and for all, so as to expand access to quality education, has special application for early childhood, which has long been left to community self-help efforts and the private sector. CISA also addresses the need for revitalization of the teaching profession. And we know that ECED is a specific area of challenge for the teacher. We need to harness the capacity of ICT to improve access, quality, and management of education and training systems. And this also applies to ECED. If we are to build scientific and technologically literate Africans, it has to start from the very beginning, using technology both as a tool and a subject of inquiry and exploration. Another important area for ECED is data and management information systems to ensure a unique identifier for every child so that she or he can be followed through the education system. Quality and accurate statistics are essential if we are to we are to be able to plan for the education and care of our children at every stage and in every place, including those in remote areas, in refugee and displaced situations, and other difficult circumstances. The African Union is keen to promote education innovation and facilitate its further development. As exemplified in the first ever Innovating Education in Africa Expo, which was held earlier this month in Senegal, the event provided a platform for education innovators across the continent to share their innovations and to find ways of scaling them up and adapting them in other AU member states. Early childhood education was a significant area of the innovations that were presented. You may be interested to know some of the innovations around ECED that came out of the conference. We had the Cameroon Youth School Tech Incubator, which exhibited a fun and creative way for children to learn programming, coding, and robotics in their native language. We also had Ubongo from South Africa, and they exhibited a system for delivering fun and animated learning content across platforms for children, including radio, TV, SMS, and smartphones, adapting it to the local context and languages. Also, Lomanji from Egypt has an innovation for teaching STEM to children using an integrated and experiential approach. The AU Assembly, recognizing the need for enhanced collaboration and alignment in education development in Africa, called for setting up a coalition of stakeholders to facilitate and support the implementation of CISA 16 to 25. This is being done through a system of thematic clusters. The CISA thematic cluster on early childhood education and development was launched on the 4th of September 2018, coordinated by the Africa Early Childhood Network, AfECN, and chaired by the African Union Commission. The AUC uses this opportunity to invite AU member states, regional economic communities, and relevant organizations and partners to join and contribute to the cluster's work. In the long term, the realization of the AU Agenda 2063, the Africa we want, depends significantly on the extent to which Africa invests in her youth, children, with quality inclusive ECED, a foundational key for harnessing the demographic dividend. We look forward to the outcome of this conference and will ensure that its concrete implementable recommendations are presented to the AU Specialized Technical Committee of Ministers on Education, Science and Technology and to the Committee of the 10 Champions of Heads of States and Governments. Thank you very much.
Thank you very much, Mr. Osu. It was a very organized and comprehensive presentation on how early childhood is promoted within the AUC in the CESA, Continental Education Strategy for Africa. And I would like to emphasize the AfECN's role in bringing this early childhood cluster in the CESA. I'm going to ask for your, the organization permission to just open the floor for a couple of questions so that Mr. Osu can respond. Any questions, hands, please? No hands, it was very clear. Yes, madam, one, and do you see any hands? No, okay. Madam, please. Use the microphone.
Yeah, our speaker just said that the Africa we want depends greatly on the investment that we make in early childhood. How much is AU putting into early childhood development in Africa?
Thank you very much. Could you could you introduce yourself?
I'm Yvonne Kepat. We are from Liberia.
Thank you.
Thank you very much. The AU is using the thematic clusters approach, which is in line with the Continental Education Strategy for Africa, 16 to 25, from 2016 to 2025. So the work is being done through these clusters, and we are happy to have launched the cluster on early childhood education and development. So it was launched on 4th of September, and there's a work plan for the cluster, which is going to be implemented over the next years. So I believe that there's the opportunity for organizations and in fact partners, relevant stakeholders to join in the work now so that we can actually all move early childhood education and development forward on the continent. Thank you.
Thank you very much. I would like to add that there are a number of good clusters in CESA. Teacher cluster, which UNESCO was, together with Education International, is coordinating. There's an ICT cluster. There's a homegrown school feeding cluster, and so on. So I would like to encourage you to visit African Union's website, where you can read the CESA and all the other activities. Please join me in thanking Mr. Mitses Osu for a wonderful presentation. Thank you very much. I understand. Yes, thank you.
Hello, how's everybody doing? Hanging in there, I hope. Okay, so we're going to have a brief 10-minute break. We're going to then move into our parallel sessions. From the program, there have been a few changes with our room, so I'm just going to announce those. So our first parallel session 1, Lead and Invest, that'll take place Shopping Village 4. That one has maintained. The Shopping Village rooms are towards lunch, towards where we had lunch. You'll follow the ushers down that way. Focus on the Families will be in Shopping Village 6. Monitor Progress will be in Shopping Village 8. Strengthen Services is going to be here in Savo. Savo is going to be on this side, and Amboseli will be on this side. So it's Strengthen Services in Savo. Innovative Practices will be on this far end. And then Leveraging Community Health Workshop, health workers, that workshop will be in Bogoria. Bogoria is where the registration was taking place, one of the rooms for registration this morning, just opposite the pool. Okay, so we're going to split into rooms. There are ushers available to guide you and to support you. And then after this session ends, about 6:30, as soon as you end, if we can have a meeting with the facilitators and presenters for tomorrow, please come, please bring me your presentations, and that will be all. What time we start tomorrow? Tomorrow is an early start again. Well, today we were late, but tomorrow, please be here by 7:45 so we can get started right at 8 a.m. Thank you.
There's innovation.
Where is innovation?
Yeah,
It's here?
I think so. I will see when the speaker speech. Oh gosh.
It's tiring.
Yeah. I've heard more music than cutting edge presentations today. No, I just said I heard more music than cutting edge presentations today. Just hold it up. I've been trying to find Portuguese translators all day, so and failing.
Now you won.
I smiled and I said the importance of language and stuff. But yeah, you can't even do it for this conference. How can you explain tools for other languages?
Well, literacy.
It's an uphill battle. Ok, eu não sei o que vai escolher, mas nós podemos se encontrar depois.
I find most convenient, I'll just pop in there for a while.
Oh, this is on.
Yeah, see you. Okay. Yeah. Yes, it is on.
What? You want to talk?
Hi, sorry I forgot something. The meeting this evening with facilitators and presenters for tomorrow will take place here in Jambo. Thank you.